Okay, so maybe Dr. Stadmauer can comment about her experience.
I've just used it more recently than you. So I had the advantage of knowing the cutoffs before, but when we look at 2D versus 3D measurements and manual measurements versus automated, the automated measurements are running on the smaller size by like 1 to 2 millimeters. So the question is, should we be in general, adjusting our 2Ds to fit the 3D measurements. And there's, in terms of time savings, there's a fair amount of training and teaching. So when we had fellows in that program, we were doing it, and in private practice, when you have, maybe that's the resistance, you have more nurse practitioners and medical assistants doing a lot of the scans. Um, the post-processing still needs to be done, and you really need to know if you have a good sweep before the patient leaves the room. So that's the physician really needs to be there at the beginning for the training process. So that may be why there's some resistance. But for time savings for the patient, the other thing is that we find the 2D definitely underestimates the number of eggs you get when you have maybe more than 15 follicles, because you're predicting. I know it's hard for the lab too in terms of media. You're predicting 28 eggs and you get 50 eggs. So where are these other eggs coming from? It's just not seen in 2D, and 3D is just more accurate in terms of that.
I agree with her. It underestimates the mature oocytes. And what we have seen is that in all our papers, doing differently by different ways, we always go to the same result. 0.7 correlates very well with the number of mature oocytes. So it could not be lucky. lucky. We are working in another work in another research to puncture every follicle individually and demonstrate that this is real. But we are using it in our routine practice, and when they have any doubt about one day more or not, it's very useful.
So really what we use basically is only 3D at this point. So we do the 3D and we really know what's going on. And when we evaluate like offline the results, like if I see, for example, the stimulation sheet of somebody, or I speak to Jairo and say, do you think this patient is ready? He only wants to know sono AVC. He doesn't want to know diameters. So, and this has given us good results. Now, I think the next step, and it's a very important project, but I think it's necessary, is to design a good multi-center randomized controlled study to show that this method is really superior to the 2D. So that's, I think.
Figure out how to design the study, because, well, the lab needs to be blinded, but it's tricky to not have a bias, I guess, in the study, even if it's randomized, to look for what criteria you're going to use for a trigger. And whether you take hormones, that the number, look at the days of stimulation, the hormonal levels, the age of the patients. There's so many different factors than to set something that's very objective in the trigger. And if it's a weekend when they're coming in, things like that.
Definitely, it's not an easy thing to do. If it had been easy, we would have done it already. But it's very difficult, and it's very also costly, because it requires a lot of work. But I think we have arrived at a point where it needs to be done. We need to really evaluate what the important points are, how we can blind it, and how we can choose the right person. Maybe a good idea would be to do donors. I don't know, but then the endpoint cannot be pregnancy, so it's tricky, definitely. But
one other thing, with COVID, we were all looking for ways to reduce the number of visits to the clinic. Does the Sono AVC help in reducing the number of visits that you need, or is it really the same?
Not the number, but just the time, because the first, we all remember the first COVID, when we didn't know anything about COVID, that we have to disinfect the room, disinfect everything. It was very, like 15 or 20 minutes thing to do before taking another patient inside the exploration room. And in this time, in a simulation, we do one volume of the uterus, volume one ovary, volume of the other. That's it. Out. 20 minutes of cleaning everything. So it was very, very useful. And then you can be in the ultrasound or with the 4D view doing the reconstruction. So it's very important. In our experience about the training, we receive residents for 2 months, and at the end of the 2 months, they know how to do a 3D reconstruction of ProVC. Very, very good. So I think in 2 months, with this type of courses, it's very easy to do the training.
So your question is about the number of visits. I guess if we believe that ProVC is more precise and more accurate, yes, we can even, if you think about the study that Jairo presented about what is the rate of follicular growth from one day to the other, we can really estimate accurately how much samples we do. So I think this is a great field where we can improve. Anybody else wants to comment? Helen? To the back of the room? You will need to participate in a randomized controlled trial study.
¿Pueden preguntar en español también?